Welcome everyone. Before we begin, I would like to acknowledge the land on which this webinar is being hosted. CIPHER is housed at the University of Regina, located on Treaty 4 and Treaty 6 territories, the ancestral lands of the Cree, Saulteaux, Dakota, Lakota, and Nakota nations, and the homeland of Métis. Please join us in considering how we can each, in our own way, move forward in a spirit of reconciliation and collaboration. A few notes of housekeeping. All attendees are in listen-only mode. To limit background noise, attendee cameras are also off. Today's session is being recorded. A link to view the recording will automatically be sent to your email address. There will be time for questions at the end of the session. I remind you that we have a 40-minute session today. We will keep time at the end, so please type your questions in the question box anytime throughout the webinar. To access real-time English captioning of this webinar, please use the link in the chat to be directed to Wordly. It's a translation and captioning service. Please be sure to keep the Wordly window open and select English at the top of your window. Pour accéder aux sous-titres anglais en temps réel, veuillez utiliser le lien qui est fourni dans la partie clavardage qui vous redirigera vers Wordly. C'est un service de traduction et de sous-titrage. Assurez-vous de garder la fenêtre Wordly ouverte et de choisir English en haut de votre fenêtre. Merci. Alors, the Canadian Institute for Public Safety Research and Treatment is hosting a two-day symposium this March to showcase research outcomes and related national efforts in support of first responder and public safety personnel mental health and well-being. Presented by public safety personnel alongside invited national consortium researchers and other CIPHER network members, this event is designed to rapidly disseminate reliable solutions and enhance the well-being of public safety personnel, their leaders, and their families. So we invite you to join us, and registration deadline is February 18th. Thank you. So I'm so pleased to welcome our speaker, Dr. Margaret McKinnon, who will be presenting Healthcare Salute, supporting our healthcare supporters during the pandemic. So today we will learn more about this fantastic project. You may write down your questions in the chat, as I mentioned before, during the presentation, and we will answer them during our Q&A session at the very end of this presentation. So let's get started.
Thank you so much, Christine. I just want to begin by thanking both CIPHER and CIPHER very warmly for this invitation to present. I want to begin by acknowledging that McMaster University is situated on the traditional territories of the Haudenosaunee and Anishinaabe nations and is protected by the Dishwaswunspoon Wampum Belt Agreement. And in making this statement, I really want to acknowledge the special contributions of the Indigenous and Inuit peoples to the lands and pledge to work with them so that all gifts of all peoples are honored and recognized. So I'm very, very honored to be here today to talk about our Healthcare Salute project and to begin by thanking again very warmly the Public Health Agency of Canada for their support of this project. I'm going to talk about a variety of different approaches that we took that were really based upon research that we conducted beginning at the onset of the pandemic, beginning in fact in about April of 2020. We were very fortunate to receive funding from the Atlas Institute, along with a very generous donation from Homewood Health to Homewood Research Institute that really allowed us to collect foregrounding information that we were able to utilize subsequently to develop Healthcare Salute as a tool that was really meant to be available for all Canadians, but in particular healthcare workers. And we chose the term Healthcare Salute for our project very deliberately, recognizing that in working closely with the military, the salute is really a sign where we thank people for their service and we honor them. And we wanted to honor Canada's healthcare workers in very much the same way that military members are honored for their service and for their sacrifice. I want to also add that we've been working on a parallel project with the Canadian Institutes of Health Research, where we're looking at also saluting the service and the sacrifice of public safety personnel over this period and now continuing into what some might consider the aftermath of the pandemic. As many of us do know, however, including those of us who have served as leaders over this period, we certainly know that with the onset of the COVID-19 pandemic, we saw that care needs shifted in the country rapidly. I can remember being part of the Department of Psychiatry at McMaster, and decisions were being made, and within moments we would have to make a different decision, send out a different message, and it often led to confusion, both for leaders, but also for frontline workers, and also for the patients that we serve through our work. We found that for healthcare workers, for public safety personnel, and also for Canadian civilians as well, that mandates, expectations, and roles changed overnight. In many ways, I served on the front lines of the pandemic. I was very honored to do so on the COVID-19 units and in the ICUs, providing mental health supports. People talked about how they felt as if on March 12th and March 13th of 2020, they suddenly shifted onto war footing. They were being expected to come in to work with great risk to themselves, potential risk to their families. Often it did feel like a war zone in our healthcare settings where there were many people dying. We were powerless in some instances to save them. We didn't know how to treat an unknown illness with unknown impact and no available cure at the time that it first began. And at the same time that this environment was shifting within healthcare, we also found that the public, of course, had the same expectations as before of us. They had an expectation that when they called 911, someone would be able to come. And we know that over this period, it was really the first time that at least I recall in Canadian history, that when we called 911, there was in fact no one to come. And that new normal that we experienced during the pandemic has continued to persist into this period now, where we know, for example, that while the public has the same expectations of us as healthcare workers and as frontline providers, we really are in a very different situation where we're very often running short-staffed. It's difficult for us to keep our emergency rooms open. We may, in fact, call in some regions of Canada and there may be no one to come, or the emergency room may not be open because simply there aren't enough people to staff it. And so we're really living even now, continuing in a period that, again, some would characterize as the aftermath of the pandemic, with very new circumstances, but similar expectations, understandably, from the public. We'll just shift to the next slide now. And so we were very fortunate in our lab that beginning around April of 2020, we began to survey the mental health and well-being experiences of healthcare workers, along with public safety personnel across the country. As of February 21st of 2023, we had actually collected online data collection looking at the mental health and well-being of close to 1,300 Canadian healthcare workers. And at this time, and this was a pattern that was consistent both in the Delta waves of the pandemic, continuing on to the Omicron waves, that we were finding that approximately 1 in 3 Canadian healthcare workers were already screening positive for a probable diagnosis of post-traumatic stress disorder or post-traumatic stress injury. And that pattern has persisted over subsequent waves of the pandemic. We also found that 1 in 6, that approximately 6 in 10 healthcare workers also displayed clinically significant symptoms of stress and anxiety and of depression. And that, again, that rate has remained relatively stable. We also know that other organizations like the Canadian Federation of Nursing Unions were conducting similar surveys at this time and finding very similar numbers, which really suggests to us that we were collecting an accurate reflection of the mental health and well-being of Canadian healthcare workers. We also found that many healthcare workers described morally injurious experiences where they felt as if they were being asked to violate their own personal or moral values simply because we had to do so in those circumstances. Good examples of that, for example, are people dying alone without family members present. Many also described that they were struggling with a sense of betrayal because they felt as if, we weren't adequately prepared going into the pandemic. We didn't have adequate levels of PPE available. We didn't have adequate training in its usage. And this was something that people struggled with because they felt as if they were putting their own lives on the risk, along with those of their families, in the face of circumstances that unfortunately at the time we weren't adequately prepared going in. And we're certainly doing a lot of work now to address those challenges and looking at, were this to happen again, I think we've learned a lot from this pandemic that helps us to prepare for future emergencies within Canada. We also found, I think, very troublingly that, it shifted over time from approximately 1 in 4 Canadian healthcare workers were considering leaving their clinical positions to approximately 3 in 5 at the last time that we collected data collection. And this was incredibly concerning to us, given that the healthcare system was already in peril, being short-staffed. So in response to this, and I have some quotes that actually are from some of the health workers in Canada talking about the influence on them. Because at the same time that we were collecting this survey data, we also conducted interviews of close to 150 healthcare workers across Canada, a representative sample of healthcare workers. And they were saying things to us along the lines of, a night before a shift, I would be up all night dreading having to go to work. I was having heart palpitations. If you want to talk about wellness, here's what it is: working conditions that are humane and that allow you to do your job properly. I can tell you from being on the units, it was in many circumstances, it verged on impossible to create humane situations. There were just so many patients and so much to be done. And some people would comment, in fact, that we're so good at caring for other people, but we're having trouble caring for ourselves. And I really did observe that in my frontline work, that people would say, I don't want to take a break. I don't have time to care for myself because I feel as if I'll be letting my team down, as if I were to do so. And I always spoke to people about a couple of things on those units. First of all, the feeling that healthcare workers were living in a different world than civilians during this pandemic period. They felt as if they were on war footing. But also there's something that we need to do in general, which can be very hard to do, which is putting that oxygen mask on ourselves before we try to help others. And when we're able to take the time to care for ourselves, we're actually much better positioned to care for others. And so what we did with the funding that we received from the Public Health Agency of Canada was that we actually set up a website-based resource that provided tools to enhance and support the mental health and well-being of Canadian healthcare workers and of their families, as well as to create mental health literacy around what are some of the common impacts of stress, like the stressors that were encountered during the pandemic, to increase public awareness around what was happening within our hospitals or clinics, so that not only the general public, but also other people who were supporting healthcare workers, be that therapists, other peer supporters, the bureaucracy, members of government, we really wanted to help to educate the public about what was happening so that they were better positioned to help others who were suffering through this, and in particular, healthcare workers. We developed clinical skills and resource training. So for example, learning how to provide trauma-informed care within healthcare settings, along with other settings as well. We provided, based on the evidence that we collected, organizational support recommendations to help organizations to better support healthcare workers. And we continue to survey the mental health and well-being of Canadian healthcare workers over this period. And so we'll just move on to the next slide now, if that's all right. So as I mentioned, really one of the primary responses that we found to the pandemic was this signature wound of moral injury. And here we found that many healthcare workers described experiencing psychological, social, and spiritual distress that really resulted from what they felt to be a violation of deeply held morals or values. And as I had said, there were many circumstances that occurred over the course of the pandemic that challenged healthcare workers and public safety personnel and military members and veterans' well-being, sense of well-being. Good examples of that include, for example, families during the pandemic understandably wanted to hold on to hope for their loved ones. And what was often happening, and I can say this from having been on the units, that patients continued to receive care for COVID-19 that was unlikely to result in resolution of their symptoms, or in fact for them to survive. And so healthcare workers were often in a position where they were administering highly invasive care, care that could be painful. So for example, proning of an elderly body, so turning them over on their stomach. And you know, healthcare workers just say that I felt as if I was providing, rather than care, I was providing harm. And that really did challenge those moral and ethical values that they had about being a member of a helping profession. Many healthcare workers also witnessed others performing actions that they didn't feel were adequate with the provision of care. And there's many reasons why that happened that we should talk about in another seminar. And as I had mentioned, also that sense of betrayal by a trusted authority figure. So someone had had a duty of care to you during the time that you were making these sacrifices, where you were risking your own life and the life of those family members at home who could also become infected by an illness which we didn't at the time have a vaccine for, or a cure for, in fact. If we could shift to the next slide, please. What we certainly know from a long-term body of research conducted primarily among military members, excuse me, but also among others, is that this sense of moral injury, of having violated one's moral or ethical values, or a sense of betrayal, has been highly associated with a host of different deleterious or poor mental health outcomes. So in association with moral injury, people describe emotional distress and suffering. They often describe continuing and lingering feelings of guilt, shame, or anger. Moral injury is highly associated with the onset of symptoms of anxiety, post-traumatic stress disorder, or post-traumatic stress injury, and depression symptoms. There's a long list here of other unfortunate mental health outcomes associated with moral injury. But I would really note, and this work done by Anthony Nazaroff, who at the time was a student at my lab, that there's also a strong association with risk for suicide with the onset of moral injury. So it really is a very, very serious psychological condition that we really need to both prevent, also provide early intervention for, and when required, provide direct long-term clinical supports for this injury. And we were really focused on Healthcare Salute on that prevention and early intervention side of moral injury. So we'll just advance one more slide, if that's all right. And so one of the reasons that we were beyond the individual level of suffering, which, you know, is incredibly significant, we also found in our work that we saw that 1 in 2 Canadian healthcare workers are currently considering leaving their clinical positions. And if previous evidence is correct, we know that at least 1 in 3 of those individuals will in fact do so. If we think about the current levels of staffing shortages in Canada, this is incredibly concerning. When we looked at our data, we found that the single greatest reason why healthcare providers were considering leaving their organization was in fact those feelings of moral injury or moral distress. And so if we think about, you know, Canada going into subsequent emergency situations, we certainly know that we need to be aware of these moral injuries. We need to be preventing them from occurring. When they do occur, we need to be intervening, for example, with psychoeducation around moral injury. I could tell you from our clinical work and from other evidence that, in fact, giving a name to this experience, saying to people, you know, you're not alone in this, that others are also experiencing this. Here's some language that you can use to talk about this. Here's how your leaders can talk to you about this as well, is incredibly helpful. And we've been really focused on that in Healthcare Salute. We did also find, though, that the presence of moral injury and moral distress was the single greatest predictor of who developed post-traumatic stress disorder, which healthcare workers developed post-traumatic stress disorder over the course of the pandemic. It provided 87% of the explanation for the onset of PTSD symptoms among healthcare workers. We've recently replicated that finding in public safety personnel, finding again that the onset of PTSD among public safety personnel was also driven largely by moral injury and moral distress that was incurred during the pandemic. And these are big numbers, they're concerning numbers, but we also found that when people had higher levels of organizational support, in fact, we saw a decrease in that level of moral injury. It really is an effective intervention for moral injury, and that's really encouraging to know. So if we shift to the next slide, I want to tell you about first of all, just to have provided that orientating information, that we were focused on symptoms of post-traumatic stress injuries, depression, anxiety, and stress, along with moral injury and moral distress. And these are the suite of tools that we developed in the first year of our project. We were able to mount these within a 12-month period. I'm going to tell you about what some of these tools were that we were able to develop. So if we shift ahead to another slide. So we developed, as I had mentioned, a full project website. We provided mental health and well-being fact sheets for healthcare professionals that were distributed, for example, to government, so high levels of government to help inform the situation. We also had them available to the public on our website. We developed and modified a tool from the Canadian Armed Forces. So really it was their tool, which we modified for use during the pandemic, that helped to increase knowledge or mental health literacy about what are common reactions to stress, what is a healthy, normal response to stress that we would expect to resolve over time. What was the level of injury that was in fact concerning and warranted seeking help? And then what was the level of injury where there was a need for immediate supports? So for example, levels of suicidality being a very clear example of that. And that mental health assessment tool could be used both for individuals, but also by organizations to assess the mental health and well-being of their teams. We know that on the prevention and early intervention side, having knowledge of the impacts of severe and sustained trauma and stress, knowing the impact that can have on both the body, on the mind, on social relationships, on functioning at work, on the ability to focus and concentrate. Actually having that knowledge has been shown to be very effective in either preventing or alleviating early symptoms of conditions like post-traumatic stress disorder. So we focus very heavily on providing education so that people could be aware of the responses that they were having, have words for them, and also in that knowledge that they're not alone, and learning some common coping skills, which we were also able to teach through these type of we really wanted to prevent and intervene early to ward off the full-blown illness, which we saw among many healthcare workers in the country. We also had a very descriptive psychoeducation module around moral injury and moral distress, again aimed at prevention and early intervention, along with a clinically guided, again, early intervention tool, which provided people with coping skills around moral injury and moral distress. And this is a visual depiction of that tool, which I don't have time to get into, but it was clinically guided by a really skilled psychologist, but really got again in that prevention and early intervention side. We can skip ahead to the next tool. These were all self-paced, could be done at any time. And we also thought about, the healthcare worker coming home at 2 o'clock in the morning, seeking mental health supports. We really wanted that to be there for them, available anytime online. We also, as I mentioned, we used the research that we had conducted to develop very clear organizational recommendations for enhancing healthcare provider mental health. These had very clear instructions, tip sheets, worksheets, infographics that could be used to implement within organizations. And we also provide an introduction to trauma-informed care for non-mental health care providers. So this is for peer supporters and also clinicians who were seeking to support healthcare providers' mental health, but doing so in a way that wasn't so advanced that it would be difficult to understand the curriculum content. It was very straightforward, plain language, self-paced, and also freely available. And what I really want to note here is that often people are seeking assistance with finding information about how to engage in a trauma-informed way, but they often have to register for courses, pay for these courses. We are very grateful for the support from the Public Health Agency of Canada, which allowed us to provide this online for free using evidence-based approaches to this. And this is work developed initially by Alex Hebert, who's the Chief of Psychiatry at Veterans Affairs Canada. She had initially developed this course, and with her permission, we worked with her to modify this course to make it available online for all Canadians. If we could just skip ahead to the next slide. We also had a series of town halls and virtual symposiums where we were able to attract hundreds of registrants middle of the day, which we also posted onto our YouTube channel, and many of them have been viewed repetitively on the channel. We focused very heavily on intersectional identity and representing the whole of Canadian experience rather than that of a narrow majority. Working with Media Girlfriends, which is a media company led by women who self-identify as women of color, we were able to travel across Canada and tell the stories of individuals, Indigenous peoples in the North, to tell the stories of racialized groups within and across Canada, and to really capture that whole Canadian experience. We also conducted, in addition to these events, we had 10 interviews that were conducted on the ground across Canada, really capturing the voices of healthcare workers. And I'd really invite you to view those online. They are on our YouTube channel and on our website. I'll let you know that through our social media campaign, we've had over 20,000 views of these videos already by Canadians, and we're very proud of that. They were also picked up by the Globe and Mail by Andre Picard, who was tweeting them out. Again, we're seeking to tell the story to enhance cultural awareness and cultural competency. And for anyone who's worked clinically with healthcare workers or public safety personnel, you will know that they often seek assistance and have to tell their stories over and over and over again. And they'll often even say that in receiving supports, they feel that they're comforting the person who's supposed to be providing the support to them. So we thought that by being able to tell these stories through these events, also providing coping skills and training within the events as well, and then this national series of interviews, we would prepare clinicians, members of government, the bureaucracy, peer supporters, to know these stories without requiring healthcare workers to have to tell them over and over and over again. And again, with that very, very heavy emphasis upon intersectional identity, which we believe to be so important in telling the stories. We had one healthcare worker named Todd who told us about his experience during the pandemic, and he talked about how he felt stigmatized as a healthcare worker, where the people were gathering outside of his hospital to protest. He couldn't wear his uniform to work. He talked about his identity as a man of Asian Canadian descent and how that he felt stigmatized within that identity, as well as his identity as a member of the LGBTQ2SIA+ community. And, in telling those stories, I think we help to open up the conversation and create space, because oftentimes these stories are not told. And when we interviewed healthcare leaders, they talked about how they didn't know what to do with stories like this. And we're really trying to provide education, training, and hope around addressing some of these disparities that exist within Canadian society. So we'll skip ahead to the next slide. So we did have a number of principles that we felt were really important. So we wanted to, again, capture healthcare provider experience. All of our research and our findings were presented in plain language. Information was chunked for quick reading. So in the middle of the night, for example, it was available in both English and French. It was online, asynchronous, self-directed learning and interventions. We had a knowledge to practice focus through interactive activities. So for example, when people watched the stories of healthcare workers, they were invited to engage in reflection exercises, which were meant to further enhance their knowledge of what happened, to relate it to their own experience, and to strengthen their learning, so that when they went back out, if future emergencies are within the current context, that they were able to engage in a way that was very thoughtful and reflective. We had a healthcare lived experience consultant panel, which was very, very important to us, informing this research. A knowledge to action committee where we advised by leaders across many different mental health fields, members of the bureaucracy, members of government, and so on, in the work that we were doing. We're now launching a social media campaign called Care for Carers, and we were very fortunate to be funded again for another year by the Public Health Agency of Canada. I'm going to show you that campaign in a moment, as well as a campaign surrounding You Are Not Alone. And so what we heard so often from healthcare workers is that they felt alone in their experiences, felt that they were the ones who had failed in some way by having symptoms of depression, anxiety, being mired in guilt and shame. And we really want to tell that story, that people are seen, we hear them, they are not alone, that Canadians value their sacrifices and thank them for their sacrifices. If we could skip ahead to the next slide. So this is the new Care for Carers campaign. Again, a very heavy focus on intersectional identity and representation in this work. These are animations that focus on interventions that can be done very quickly. So preventative approaches, early interventions approaches like a body scan, self-compassion and self-care, having awareness of our breathing and engaging in breathing in a way that's actually quite helpful for lowering levels of arousal, and so on. Really common tools that we use within, I would say, our toolbox as clinicians, as a clinical psychologist and others, that we can use to prevent the onset of further symptoms, but also to intervene early when people are experiencing mental health difficulties and stress-related responses. So we had really good pickup on these already, and we're really pleased with this work. If we could skip ahead to the next slide. We also have, again, working with Media Girlfriends, traveled across Canada to conduct interviews with leaders, healthcare leaders, because we really want to be clear that leaders also suffered during the pandemic. I worked quite a bit, not only on the front line, but also in, I guess people would call it the senior leadership team, to help support senior leaders. I also sit on the board of a hospital here in where I live, and I really recognize the sacrifices and service of healthcare leaders as well. So we conducted interviews with them to tell those stories, and again, to take lessons from the experiences of these leaders, as well as to help leaders themselves not feel alone. And it's a way of preparing for, any future circumstances that we may face through these interviews, which I think will be leveraged going forward for those circumstances. If we could skip ahead one more slide. We also have our Expressing Gratitude campaign, So You Are Not Alone social media campaign. And we're reaching out to Canadians, really asking them to tape 30 to 45 second messages, focusing on their gratitude towards healthcare workers, and also for people to share their own experiences during the pandemic, including healthcare workers. So if we could skip ahead again. We do have an upcoming symposium next week on February 22nd, where we're going to be talking about healthcare leadership. It will be a series of individuals who have been involved in leadership during the pandemic, along with researchers and clinicians, presenting both our research findings, but also having open discussion around some of the challenges that were faced and some of the lessons that were learned. And that will be available through registration. The QR code is here, which we'll put up again at the end. And you can also Google this if you'd like to participate in this seminar, or symposium rather, which we're calling Navigating the Fog and the Role of Healthcare Leaders in Supporting Provider Mental Health During the Pandemic. This is again sponsored by the Public Health Agency of Canada. I want to note that as part of our work, we really did reach out to a host of different media and artists across the country to support the work. And it really was an opportunity to engage in bringing science out to Canadians in a way that we hoped would be engaging to them. So we used visual renderings. When we started looking at stock photographs, we realized very quickly that they didn't reflect how healthcare workers look, the burden upon their bodies. They were often not representative. And so we worked again with artists to really create imagery, animations that represent the whole of Canadian society, and again, not a narrow segment of it. We're really, really proud of that work, including our lead partner, Make Things Well, which really supported us in this work. If we could move forward again. And I just want to note again our thanks for the support from the Public Health Agency of Canada, and to acknowledge our partners, including the University of Alberta, Conestoga College, St. Joseph's Healthcare Hamilton, Homewood Health, Homewood Research Institute, and of course CIPHER itself, which has just supported us so wonderfully throughout this project. So thank you so much. We'll just skip ahead one more slide and we can transition into questions. This is just information about our upcoming seminar. Oh, this is about this seminar, but let's go ahead one more. I think we have information about the upcoming seminar as well. So thank you so much for your attention to this. Here's a link to our website, and we're really excited to answer questions. So thank you so much.
Thank you, Dr. Margaret McKinnon, for this wonderful presentation. We've learned so many things about the very I would say, prepared resources, and they're very accessible too, so that's great. We have one question here for you. What are tangible steps that leaders can take to acknowledge the challenges that healthcare workers have experienced and move the organization forward in a positive direction?
No, thank you so much for that question. And I think it's been really interesting going out and giving talks to leaders and to frontline staff, where oftentimes simply acknowledging and talking about people's experiences is enough to lift, in some ways, the burden. So, for example, by beginning a talk or an interaction with frontline staff and saying, we recognize, for example, the moral injury and moral distress that you've experienced, and then describing that, describing examples of that, opening up the space for people to talk about it. Oftentimes it's very interesting that that can be in large part a way of moving forward in a positive way as well. So having that conversation, giving people words to talk about it, and also for leaders, it's really important for us to also acknowledge our stresses and our strains. I can tell you as a person with lived experience of PTSD and of depression myself, which I'm very much am open in describing, having those conversations I think is really important to help others to feel that they can open up and talk about this as well. So I would really encourage leaders as well to share their struggles that they had over this period, because we know that we're all in this together. Frontline leaders, supporters, we're in this together. And I think it's really important to also acknowledge that we were all doing our best, the best that we could, under very difficult circumstances.
Yes, thank you so much for that. I don't know if we have any other questions from the audience at this point. I don't think so, but if there's anything else you would like to add for this presentation, Dr. McKinnon, you're welcome to add it now. We still have 2 minutes.
I think what I want to say is that I think we learned a lot during this pandemic. We learned many lessons during SARS, but I don't think we took the time to leverage those lessons prior to the onset of the COVID-19 pandemic. And I think we're now in a position in Canada where we can be a leader in preparedness for future pandemics, future emergencies, future disasters, because we did the research in Canada. We were supported to intervene through this funding from the Public Health Agency of Canada. And now how do we take those lessons that we learned the past several years now and leverage them to prepare for whatever may come next? It's hard to say that because we don't want to think about the next circumstance and the next challenge that we'll face as Canadians, but we will be facing these challenges. And I think it's really important that we now take the lessons that we've learned and the tools that we've developed and leverage them forward for future preparedness. So thank you so much again for this opportunity. We really appreciate it. We also want to just say we thank, support, and salute healthcare workers, public safety personnel, military members, and veterans for their service, for their sacrifice that occurred over this period and continues on today. Thank you so much for everything that you've done.
Thank you for this. I have some more questions here coming up. So what has been your proudest achievement during this project, if you have one?
Good question. You know, I think reflecting on what I saw during the pandemic, I think for us it's been being able to tell the stories of healthcare workers in a way that we hope actually assists them, right? So, you know, hearing from Todd, hearing from others who talked about, for example, being members of equity deserving groups, going to work, seeing that members of their community were disproportionately represented in hospital beds, and finding a way to make change surrounding what we experienced, I think are our proudest moments from this, and really being able to continue to leverage those lessons to continue change and preparedness.
I'm going to take one last question here. Was there any hesitation from the healthcare workers to film their experiences during the pandemic? And how can an organization connect with social leaders within healthcare that drive change?
Thank you so much for the question. Yeah, I think that that's a really tricky question. I mean, I think different people have different levels of comfort disclosing you know, their experiences. And I think what's most important is that this is done in a trauma-informed way. So, you know, recognizing the difficulty of speaking about this, providing supports during and afterwards, also being able to, you know, open up a conversation around difficult things to speak about in a way that, again, offers those supports during that time. It was a lot of service and sacrifice that people gave to tell their stories. And we're very, very grateful to those people who did so, and also to the people who didn't do so, because, you know, it's very, very difficult to do. And, you know, even yesterday I was involved in a clinical case where, you know, the person who had experienced occupational stress really, you know, didn't was worried that by telling the story that they would harm others, including their family members. And so there's a lot to unpack when we talk about telling these stories. And I think it's important to recognize everyone and the approach that they take around the stories. Thank you.
So thank you so much to you, Dr. Margaret McKinnon, for such a wonderful and engaging session today. We would like also to thank you, the audience, so everyone attending today, and thanking also CIPHER for providing a lot of technical support and being able to host this webinar. So thank you again to everyone and wishing you all a very nice day. Thank you.
Everybody, thank you so much. Thank you, Miss Christine. Take care.